how to treat people with additional oxygen devices, right? Should they be in distress or should they have issues with, hypoxemia, right? So everybody knows their indications for oxygen therapy, right? So documented hypoxemia, what else? You want to sit closer or indications for oxygen therapy. What was it?
SpO2 less than 90.
So an SpO2, a PaO2 less than 60, right? And then obviously if you see somebody who's in distress.
Accessory muscle use.
Yeah, accessory muscle use, diaphoretic, right? In distress, then I'm going to place them on some type of oxygen device that I know is appropriate for them, okay? Sometimes those devices work and it helps alleviate their symptoms. Sometimes it doesn't. So when it doesn't, like let's say we put them on a non-rebreather or a Venturi mask and they're not getting better, and then we put them like on a high flow, remember the high flow device? Where it delivers a high level of FiO2 and then a higher flow, and they still have issues with work of breathing, then we have to think of non-invasive use of this machine right here, okay? So this machine, what it does is it provides a pressure and a volume to help supplement what they're not able to. What was it? Oh. So basically, this is a non-invasive way to help a patient breathe. Okay? So non-invasive, and by non-invasive we mean we're not putting anything inside of them. We're just placing a mask. It's called a bipappap. Mm-hmm. Okay?
So mechanical ventilation is invasive?
Is invasive, yes. Mechanical ventilation, a ventilator is invasive because I actually have to stick a tube down their throat. And this is non-invasive because all I do is I place a mask, okay? And this is what we call non-invasive. But it works really well because we help deliver a volume in their lungs. We can help deliver pressures, and we can help give oxygen levels, and then we have other little things that we do on here to kind of fine tune. Right now, all of us are breathing fine. We're all maintaining a good volume in our lungs. Do you guys know your average tidal volume? What's like an average tidal volume? Yeah. And we're breathing about, how often do you guys think we breathe per minute?
15 to 20.
Yeah, normal's like 12 to 15. So with our respiratory rate and our volume, we're maintaining good oxygen levels and we're blowing off the CO2 that we need, right? But what if somebody overdosed on something, or what if they got really drunk and they just like knocked out? Then they're going to have a hard time maintaining that volume because their breathing slows down and their oxygen levels drop. So that's when these types of things come in and we help replace that. Okay? So we give them a volume and we can also help them with the respiratory rate. Okay? A ventilator is life support. It does all that for them. This kind of helps them. It's like a trainer where you're helping them, okay? But a ventilator, we take full control of that because we sedate them and then we let the ventilator do all the breathing. Okay? All right, so this is a BiPAP, okay? And I'll just go over some of the mechanics of it. So all BiPAPs have a circuit, okay? And they look similar to this. And the circuit is a large bore. This little device right here is, we call it the exhalation valve. Okay, so this little hole is very important. There has to be some type of exhalation, because what would happen if this wasn't there? It's an exhalation valve. Yeah. Your patient there would be nothing coming out, and my patient would be rebreathing their CO2. Okay, so this is very important. So if your circuit doesn't have an exhalation port, then that's an issue.
Exhalation port.
An exhalation port or valve. Okay. Now this circuit has it automatically on here. There's some circuits who they come without it. So you actually have to go to your department's equipment room and find one to put it on here. Okay? Now this machine is really nice because when you calibrate it, it tells you, does your circuit have an exhalation port? And the old one, this is the old one that I was using, it doesn't tell you that. So it's kind of dummy proof, right? So this is an exhalation port. This is just some additional tubing for your pressure, and then here's a bacteria filter that it comes with, okay? And so the way it works is you put your bacteria filter this way right here. This little device, this little tubing goes right over here. And then this is where the mask would go. I'll have to find it, but your mask goes on here, okay? This is the old one. If you look at it, it's pretty much the same concept.
files already set up for us, and then from there, we're going to analyze what we think and then go.
Okay, so the back of it. What do you guys notice with the tubing?
It's just connected to the oxygen and then the power port.
This actually is connected to the wall outlet. And it's green, so it goes to the green one, okay? And then this is the power cord, okay? So, do you want to take off that one? And the way you have to take it is just kind of twist it. And it's going to make that noise.
It always
Okay.
is scary.
And see the way it looks, the threading just goes in exactly like that, okay? Straight in.
It doesn't feel like it's on them.
Make sure the little threading is like directly, do you want to put it in? There you go, okay? And then, okay. Okay, so your machine will not work without the oxygen. Now the nice thing about this machine is that it has a backup battery. So if you don't plug it in, it's going to tell you it's running on the backup battery, okay? And it will alarm and tell you that. This one does not have a backup battery. So when I started working in the hospital, there was a night that I had like 8 patients on this. I had a lot of patients on this, and our lights went off, right? And the generator didn't kick in. So my supervisor called me and he said, Delmy, take off all your patients from the BiPappap. Put them on oxygen because these don't have a backup. Otherwise they suffocate. With the mask on, you know? Just have a mask on and not comfortable. But these do, and these will tell you that they're working off the battery, okay? Which is nice. All right, so oxygen connection to the wall, plug in, okay? Here's my tubing. All right. Okay, so what types of patients do you guys think I'm going to put these patients on BiPappap?
Drug overdose, right?
What was it?
Drug overdose.
So that's actually, let me tell you the contraindications, okay? So your patient, you do not want to put patients who are not able to follow commands, not able to maintain their airway.
So wait, you don't want to put someone on there? Okay,
Yeah.
so
Yeah,
It's
it's contraindication, okay? So people who are, what did I say? I forgot what I said.
follow, yeah.
Okay. Not able to protect their airway. Do you guys know what that means? So do you think like somebody who's overdosed can protect their airway? Like if they're overdosed, comatose, really lethargic, and they're like good?
Oh, yeah, okay.
Yeah. Okay. Somebody who's coughing up blood, and somebody who's apneic. Apneic means not breathing. If they're apneic, what do they need? They need to go on
the
ventilator. Okay? So basically, your patient has to be breathing spontaneously. Okay? So I don't want to put somebody on, your goal is to alleviate any work of breathing or help them with their breathing. But if they can't take off the mask, if they can't follow commands, if they're apneic, if they're coughing up blood, they should not be on here. Okay, because it's more of a risk and maybe they should be on that. Okay? So there's a lot of risk with this if your patient can't protect their airway. What if they vomit? And then they vomit and then the vomit just goes back into their lungs, they aspirate, okay? Can it happen with your patient being alert oriented? Yes, it's happened to me. But I mean, if somebody's like, those are contraindications and you have to advocate sometimes for your patient and tell your doctor like, hey, my patient is not able to take off his mask, he can't follow commands, I don't feel comfortable putting him on this. So if we put it on him, you know, your license, not mine. Okay? So those are some big contraindications, okay? So basically your patient has to be breathing spontaneously.
What if a patient has sleep apnea? Would it be a CPAP or?
Yeah, so sleep apnea is a little bit different.
Oh,
But yes, sleep apnea, you use a CPAP, and you can do CPAP on here as well. And CPAP, basically what it is it's a constant pressure that stents your airway open, and it prevents you from not breathing. From breathing. From not breathing, so it helps you breathe at night. Yeah. But we use this for also sleep apnea patients.
so is it just a different mask for?
Yeah, it's a different mask. Maybe some of the devices are smaller, you know, but similar concept to where your patient should be alert oriented, and we just use it at nighttime. Okay? But yes, CPAP. What was it?
While they're asleep.
Yeah, while they're asleep, because what usually happens with sleep apnea patients is they fall asleep, and then their trachea collapses, and then when it collapses, you stop breathing, right? So we have to do sleep studies on them to figure out what pressure keeps their airways open, and then we set the CPAP on that pressure. Okay? And that pressure, like let's say a pressure of 20 keeps their airway nice and stented open, then they no longer stop breathing with that pressure. And their oxygen levels are good and all that.
So just to be sure, this is the machine that is connected to the deep fake glass. That
Yeah.
is
Yeah, so it's basically a mask. Well, this is what it looks like on the mask, but I'm missing something here. This is kind of what it looks like.
I've seen that.
Okay. Okay, so let me give you guys a scenario. Okay, so I have a patient, an old patient who has dementia and who's having trouble breathing, has a really bad pneumonia. When I explained to him how to take off the mask, he didn't understand. Would I put him on a bipappap? No. Right? Okay. I have a COVID pneumonia patient who is breathing 40 breaths per minute, hypoxic, okay, so low SpO2, and high flow's not doing much for them. So would he be a good candidate for the BiPAP? Yeah. He's able to, if I explain to him how to take off the mask, he can take it off, okay? I have a patient who got diagnosed with TB, and they're coughing up tons of blood. No. Yeah, I can make it worse, right? Okay, and coughing up blood is hemolysis, okay? Another thing is if they have a lot of secretions, we usually don't put them on here as well. So, and I'm talking a lot, like just copious amounts of secretions, because then they can aspirate on that.
Look at your vital signs.
Okay? All right.
So just the indications would be breathing spontaneously and then sleep apnea
So
patients?
indications can be a lot of different things. So one of the big indications is, bless you, is acute respiratory distress, acute exacerbations of like COPD, right? Acute ventilatory failure. So issues where somebody would have trouble breathing, and whatever we did with like oxygen devices is not working. Okay? So any type of respiratory distress that acutely happened, we use it for like COPD, patients who have left heart failure, we call it CHF, so that's an indication, okay?
So when they look at you,
Would you ever take, like,
breath down.
put a patient on this who just came off mechanical ventilation?
Yeah, we do.
There's,
That's a very good point. So I'll tell you, like patients who come out of heart surgery, like let's say they had open heart surgery, and the doctor's like, the sooner we get them off the ventilator, the better, the safer it is, because being on a ventilator is very high risk, and the longer you are, the harder it is to get off of it. So sometimes what the doctors will tell us, is they just had open heart surgery, extubate them, and then put them on BiPAP for like a day or two, just to kind of get them over that hump. Especially because imagine having like a big incision and trying to breathe on your own. It's hard to take a deep breath in, get your normal volume of 500, and then have a normal respiratory rate where you maintain CO2 and oxygen. Those types of patients get really tired, and the pain is very bad to where you need support to help you. So yes, we do. Very common. For post-op major, we call them upper thoracic abdomen surgery. So any major thoracic abdomen surgeries, if they're high risk, we would like to either leave them on the ventilator or pull the tube and put them on here while they get better. While they wake up, while they, their pain's more controlled.
Then I would say, after my treatment, I would ask if he's okay. I would do my ending assessment.
So any questions on contraindications and indications?
You said,
I said.
yeah, I'm trying to get that part. So you said if they have sleep apnea, right? You can put them on. But then you also said.
You can put them. So the way you got to think about it is CPAP is used for patients who have sleep apnea, where they just have oxygenation problems.
Okay.
There's some people who have apnea where they run into oxygen problems and issues with retaining CO2. So when they run into those two problems, then we use a BiPAP, because a BiPAP has more fine-tuned controls where I can set like a volume and a rate. And BiPAP is just CPAP is just a pressure. So if you use this on somebody who has sleep apnea, it's pretty severe sleep apnea. Oh, yeah. And there's some machines that are home use that are BiPAPs are small. Mm-hmm. It's just not as like detailed as this one. But yeah. And we usually so I'll give you an example of people who use BiPAPs for sleep apnea. Like morbidly obese patients run into issues where they stop breathing at nighttime, apnea. And what happens is the CPAP just did not cut it. So they need a BiPAP because the BiPAP has two pressures, and then I also can set like a backup respiratory rate to help them. And the CPAP does not have that. The CPAP is just one pressure regardless if they inhale or exhale. So this is a little bit more detailed where I can kind of fine tune and help their breathing. Okay? Good question.
And then what would be like a hazard or like a hazard for that? It'd be like
a hazard?
them choking
okay,
on.
So a hazard, I can cause aspiration.
Okay.
Right? I can cause. This is a pressure that I'm delivering, so I can cause a pneumothorax. You guys know what a pneumothorax is? What was it? Excess gas, air, So if I don't know how to use my pressures correctly, I can actually cause a pneumothorax, right? I can cause hemodynamic instability, like maybe arrhythmias with that pressure. Let's see. Those are like your big hazards, okay? Okay, so I want you guys to turn it on. You guys see your on-off button?
Oh, I hated that sound. Oh no. Sometimes I go when I can still hear this. Yeah, especially the time.
Okay. So I don't want to go over too much on the modes because it might be a little too much, but it's okay. So this is what your screen looks like. It's called the Philips V60 Respironics. And we call it a BiPAP. Okay. ST means BiPAP. It's called spontaneous time. So when you guys hear ST, it's what it's called. And then here are your settings for your BiPAP. If you go to mode, these are all of the other settings right here. Okay? So we have CPAP, right? Which is what we would use for what instances did we say? Or you guys even mentioned to me. When would I use CPAP?
For home use.
Home use, right? I mean, you could also use it at the hospital too. Like you'll use it a lot at children's, babies are on CPAP, but we use it for like sleep apnea, and it's also really good for like oxygenation purposes. Okay. AVAPs and pressure control ventilation is a whole other mode. I won't talk about those, but this is ST means BiPAP. Okay. Okay. So with your BiPAP, you have these are all your settings. Okay. So I have a pressure on inspiratory phase. Okay?
Yeah.
And the pressure on the inspiratory phase, the lowest it can go, it tells you right there 4, and it can go as high as 40. Okay, so there's a pressure that you reach on inspiration. Okay? There's a bottom pressure, it's called EPAP, which is an expiratory pressure. This is a little bit lower, it goes 4 and it could go as high as 25. Okay? Here's a rate, okay, a respiratory rate that I can set. It defaults to 4 and you can go as high as 60. Okay?
Is that on top of what they're already breathing?
Exactly.
Okay.
Yeah.
Okay.
So if somebody's breathing, like let's say you put somebody on there who's breathing like 40 breaths per minute because they have a really bad COVID pneumonia and they're huffing and puffing, do you think I would set this lower or higher? Lower, right? Because if I set it higher on top of what they're doing and that, yeah, they're gonna be very asynchronous. So the way you gotta think about it is I use this more for patients who are breathing a little bit slower on top of what they're doing and help them blow off any CO2. But if like somebody comes in and they're like huffing and puffing, but they need help with their work of breathing, I usually set it like at 6 or 8. Okay? So good question. Okay? So this is another option to help blow off CO2 if my patient's not breathing. Like let's say they're breathing like 10 or 9. You're like, oh man, that's slow. Yeah, shallow. I'm going to increase that rate to 12 on top of what they're doing. And then once they start to breathe faster and wake up, then you go down on it. Okay? Got it? This is a time on inspiration. So normal eye time is about 0.6 to 1 second. So we usually leave it at like 1 second. I don't want to go too much into that, but it's basically your inspiratory time, your time during the inspiratory phase. Okay? This is your oxygen percentage, right? So we all are breathing 21% oxygen, right? But we can go as high as 100%. So you would change that to maintain a good SpO2, right? So if my patient's SpO2 is 88% on 40% FiO2, then you're like, oh, let me go up to 45 or 50 to normalize it to their 94 or 95. Okay? So you use this to maintain a normal SpO2 for your patient. Okay? What percentage of oxygen is considered hazardous?
Anything under 92.
What was it?
Oh wait.
Oxygen FiO2.
It's
When do we? 60. So at 60% FiO2, we're like, oh, that's like high FiO2. So I'm at risk for like what? What is it called? Washing out the nitrogen in my alveoli.
Oh,
It's
absorption
causing-
adolescence.
Yeah, I'm all, what is it
It's causing
called?
absorption adolescence.
Yeah.
So just know that high levels of FiO2 for long periods of time can lead to oxygen toxicity. And when you're like 60-70% and you're still having problems oxygenating, you got to think of pressure to help keep your alveoli open. So I may have to adjust my pressures. Okay. Your rise. So okay. Your rise is basically this pressure going up to your BiPappap, okay? So what do you guys notice about the setting of 1,
It's only 1 to 5.
2, 3, 4, 5?
The curves the slope, it slope a little bit, so
It's like goes steeper, right? So 5 is the
One is-
steepest and 1 is the
Oh, no.
fastest, right?
Okay.
So 1 is, it's like going up a hill, right? So if I had a patient who comes in and their work of breathing is so bad, would I want this breath to go faster or to go slower?
Slower.
slower.
You want it to go slower if they're having a hard time breathing?
Oh,
Oh,
That's
sorry,
faster.
faster.
oh, I don't know. I was
want it to
thinking
get-
easing them in.
You want it, so if somebody comes in and their work of breathing is like,
Then you want it to go
then
slower.
I'm like, you know what? I want this breath to be delivered a little bit faster. Okay? And then once they start to like stabilize and normalize, they'll be the first ones to tell you like, I feel like I'm being smothered. I feel like and then you're like, okay, let me slow this rise a little bit down. Okay? You guys can try it. It feels like you'll feel the difference from 1 to 5. But I mean, imagine if you're having a hard time breathing, you want that breath like as soon as you want it to reach to you as soon as possible.
Okay.
Okay? So this is all patient comfort. Like there's no like textbook where it says set it at 3 for this. It's more like my patient's coming in, they're having a hard time breathing. I'm gonna set it to 2 right now. Oh, your breathing looks a lot better now. Don't tell them what you're doing, just kind of fine tune things, So those are your settings. Okay? Let me ask Diana if I can get her mask. She has a mask and you guys can put them on, okay?
Oh, now it's not glaring.
It's blurry?
No, now it's not.
Oh.
Like the whole time it was like, see how it's there?
Yeah.
Once we've done.